Hi class, this is Adrian. I'm going to share with you my quantitative project. The study was Return of Bowel Sounds Indicating an End of Postoperative Ileus by Robert Macy in 2012. Ileus is a block-up of solids, liquids, and gases in the intestinal tract caused by decreased or absent peristalsis. This can commonly happen after surgery due to muscle and nerve function. The problem with this is postoperative ileus, besides for being painful, can increase hospital stays for 3 to 5 days, up to 3 to 5 days, and increase the cost of health care by billions. The other problem with POI is that we traditionally used the presence of bowel sounds as an indicator for the resolution of POI. This has been used since 1905. It is a fairly outdated method, although traditional, and there are also other indicators that can be used. So the purpose of this study was to determine if in fact it is an unreliable indicator, and also to determine if this should be the primary assessment for nurses to use to determine if POI has resolved. Not that it is not a good assessment, but it should be the primary and only indicator. Also to determine if a rocking chair will help increase GI motility, and also is there any correlation between the return of bowel sounds and the passage of first flatus. The research objectives were to determine the effectiveness of the rocking chair on the duration of POI, and determine if there is a correlation between passage of first flatus and return of bowel sounds. The questions are, does the rocking motion help decrease the duration of POI? When do bowel sounds return for the rocking group compared to the control group? Is there a difference in time frame between the presence of bowel sounds and the passage of first flatus? The literature review was done with Medline, Scopus, and Sinon. He also used a snowball research effect. This is taking old data and moving towards the newer data. Not all of this was included in the study, but that was the primary investigator's method of literature review. There were 26 studies. Actually, 8 were only nursing journals, 15 were surgical and medical journals, and 3 were therapy journals. Macy also included his 2010 experiment on the rocking chair intervention. He didn't include many details on that method or if there were any limitations or extraneous variables to it, just that he did this in 2010 with the rocking chair and the same sample used for this study. There were no theoretical frameworks directly mentioned in the study, however, some can be derived. As you can see from the literature review, the 15 surgical and medical journals used, this was a borrowed theory. Bowel sounds as evidence of the end of POI, return of flatus, and even the rocking chair intervention to decrease the stress response by stimulating the vestibular nerve. These are all borrowed from medicine. These are not nursing theories. There is a nursing practice theory in the auscultation of bowel sounds at the bedside, which is a long-standing nursing practice. However, doctors use this as well. There was no map or model provided for this study. The design was a post-test only design, 2 groups, control, intervention, the rocking chair interventional group, and the control group which received standard care, which was ambulating and sitting out of bed daily, no time specified. And also the return of bowel sounds and its association to the passage of first flatus, if there's any correlation between the two. The variables, the independent variables, the rocking chair motion, the dependent variable is the duration of POI, and the research variables, the return of bowel sounds and passage of first flatus. The rocking chair motion was defined conceptually by, it stimulates the vestibular nerve and the reticular activating system, which is thought to decrease the stress response after surgery. This was defined operationally as 10 to 20 minute increments for 1 hour per day in the rocking chair. Postoperative ileus was defined conceptually as the absence or delayed GI motility that causes gas and fluid retention in the GI tract. And this was defined operationally by the daily auscultation of bowel sounds and subjective assessment of passage of first flatus or passage of bowel movement itself. The research variables, first flatus was defined operationally by subjective assessment, asking the patient the same time every morning if they have any flatus. Return of bowel sounds, which was operationally defined by the auscultation of bowel sounds, 5 minutes in each of the 4 abdominal quadrants, the same time every morning. So what is the rocking chair intervention? Like I said, the rocking chair intervention is thought to decrease the stress response, and this was used to see if it would decrease the duration of POI after abdominal surgery. It actually is used after C-section as well. The sample was 66 patients, all recovering from abdominal surgery to remove cancerous tumors. The researcher used random assignment, which is randomly assigning the sample into two different groups, the intervention group or the control group, 32 in the control, 34 in the intervention. No demographics were included, and this was a purposive method. All of the participants had to have the same digestive system cancer tumor removal of the abdomen. The inclusion criteria: digestive system cancer, abdominal surgery, English speaking, the cognition had to be intact, ability to ambulate and sit up in the chair, and medically able to receive patient-controlled or IV epidural analgesia. The exclusion criteria included patients in a different hospital, non-English speaking, confused patients, cognition not intact, not able to ambulate or sit up in the chair, not able to receive the IV or epidural analgesia, patients who did not suffer from POI, and patients who had other surgeries other than the ones specified. The data was implemented daily. The control group was ambulated daily and sat in the rocking chair daily. No time limit was specified on this or time of day. The intervention group did the same 2 interventions. However, they also sat in the rocking chair for 10 to 20-minute increments for a total of 1 hour per day. The study did not specify who implemented these interventions, whether it was the primary investigator or the nurses on the floor. The primary investigator was the only one to auscultate for bowel sounds, 5 minutes in each of the 4 quadrants every morning, same time every morning, and also ask the patient if they've had return of flatus or bowel movement, same time every morning, and the primary investigator noted the date and time of these assessments. So the results: there was no significant difference. You can see here the control group, 2.25 days to first bowel sound, and intervention group, 2.21 days to first bowel sound. 2 days, not a big difference. You can also see that from the t-test here. And the second aim of the study, the correlation between first flatus and return of bowel sound, also no significant difference, as shown here by Pearson's correlation, which shows the correlation between 2 different variables, which is 0.231, which is little if no significant difference, or little if no correlation. The author really did not mention many limitations for this study. He did, however, say that there should be more research done to see if there are any other interventions that can be used on our patients to decrease the duration of POI, and what is the best indicator of the resolution of POI. Is it bowel sounds? Is it first flatus? Should it be a combination of the 2? Other limitations I derived from the study: the medications the participants received was not included. We know that most patients receive bowel meds, laxatives, stool softeners. No mention of this was included in the study. We learned in pharmacology this semester that narcotics, iron, anticholinergics, and chemotherapy can also harden the stool and cause a decrease in bowel movement. So these would be factors that could affect POI and bowel motility. Comorbidities: did any of the patients have any other GI diseases, irritable bowel syndrome, diverticulitis, maybe something that would cause GI motility or bowel movement to increase quicker? What was their diet? Did they eat anything at all? Were they on a liquid diet? Were they NPO? Did they have a tube feed? We don't know. It was not included in the study. And can the findings be generalized for all patients? The author cited that these findings should be generalized for the rocking chair intervention group, should be only generalized for the abdominal patients receiving tumor removal. However, there was really no increase in the duration or decrease in the duration of POI, so it really would only be a comfort thing for the patient. The nursing implications: the return of bowel sounds as an indicator for POI should be used with caution and used in conjunction with other methods. Other symptoms of POI are nausea, vomiting, decreased appetite, abdominal distension. So the absence of all these or the increase of the appetite, all of these should be used together to see if POI has resolved itself. So in conclusion, like I said, we need to use all of these things together. The findings are only generalizable to the sample population. There really is no correlation between passage of first flatus and return of bowel sounds, and the very little correlation shows that we should actually be using both of these. The rocking chair intervention, it did not decrease the duration of POI. However, if this is a comfort because it does decrease the stress response after surgery, we can allow our patients to sit in a rocking chair if they would like to, and it's provided. And further research really should be done to investigate what are the other interventions that can be used for our patients. What can we use to decrease POI, get them comfortable again, get them home faster, and decrease healthcare costs. Thank you.